Hello, in this presentation we're going to quickly talk about some of the standard echocardiographic windows, sort of 2 out of 3 major echocardiographic windows. Very quickly, you would get hopefully a lot of practice with those when you come for the course, and there would be an introductory lecture at that time. So this is just to give you a quick orientation, just to prep you up. So the first view that we normally do in echocardiography is what is called as a parasternal long axis view. Parasternal long axis view has a probe with its marker facing towards the right shoulder. It's usually between the second and the third intercostal space, just lateral to the sternum. The patient position, the optimal patient position for any echocardiography view is them leaning slightly over to their left side with their palm placed under their head, in order to get the shoulder out of the way and also open up the intercostal spaces. So why do we do this view? Well, to look at the heart, but in specific it helps us evaluate the two ventricular chambers, mainly the right ventricle size and the left ventricular size. This also gives us an idea of the left atrial size, particularly in relation to the aortic valve. It also helps us evaluate two of the valves, the aortic and the mitral valve, which we can see quite well. Obviously you can see only 2 leaflets out of 3 in the parasternal long axis of the aortic valve. We won't go into the details as to what exact those 2 valve leaflets are, but you can at least see 2. You see a part of the ascending and the descending aorta, and then you can sort of ascertain the pathologies with those. We've already talked about how we do it, and the main structures seen are here on your screen. So the anterior most structure that you see is the right ventricle. It's sort of cut it in sort of a mid-axis, so it looks small on this view. In fact, they say that if it looks it should be inconspicuous, and if it's looking prominent, then there might be a pathology with it. Then the next thing you see is the interventricular septum, and I'm going anterior to posterior, by which I mean that I'm going from the upper part of the screen to the lower part of the screen. You see interventricular septum, you see left ventricular cavity, then you see the posterior wall of the left ventricle. Towards the right of the screen is the left atrium with the left atrioventricular valve or the mitral valve, and the left ventricular outflow tract with the aortic valve in place. So in an image, the parasternal long axis view looks something like this. Again, the structures have been named for your convenience. The end that is right at the top of the screen is closest to the probe. So the structure that is highest on the view is closest to the probe, and hence is most anterior, because our probe is anterior. And as you go down, you move from anterior structures to the posterior structures. The right ventricle is the most anterior structure, and descending aorta, which has not been named in this picture, but is just it is the hollow structure just posterior to the left atrium. It's a sort of an elliptically seen in this picture. Most of the time you'd be able to see it as a round structure just posterior to the left atrium. So that's the descending aorta. Again, as we went through the structures, right ventricle will start with, or right ventricular cavity more precisely, interventricular septum, left ventricular cavity, posterior wall, and then coming onto the right side of the screen you have left atrium with a mitral valve, which is a bileaflet valve, and then the left ventricular outflow tract with aortic valve, and progressing on to ascending aorta. So these are the sort of structures that you see in the parasternal long axis view. After the parasternal long axis view, we go to the parasternal short axis view, and by the short axis, it means is that you rotate your probe 90 degree. So if you like something that you were looking at from a sideways view, you now see it from an end-on view. So which means that the left ventricle, which was appearing long or oblong in the long axis view, appears sort of like a donut in the short axis view. So how do you get this view? You get the left parasternal long axis view. You keep the mitral valve right in the center of your screen, and then with your other hand you rotate the probe 90 degrees anti-clockwise, and what you then get is what is called as a parasternal short axis view at the level of the mitral valve. Why do we do it? Well, this view gives us a lot of information, and the reason it gives us a lot of information is that we actually do it at a few different levels, which we'll see as we go along. So it helps us assess the cavities, the left ventricle and the right ventricle. their relationship with them. So which is the more dominant ventricle? Is right ventricle dilated? Is it putting some pressure on the left ventricle? We can assess the global and regional left ventricular function. So you can see all the different walls of the left ventricle at various segments. Again, I would not go into the details, but just suffices to mention at this point that you are able to ascertain the regional and global LV function in this view. You're able to ascertain the contractility at various levels. There are a lot of valves that you can see in this view. I think apart from the mitral valve, well, you see mitral valve in short axis, but you can see tricuspid, aortic, and pulmonary valve in this view. So it gives you quite a good overall impression as to what's going on with the heart if you were to get this view right. You're able to also see pulmonary artery, which is difficult to see otherwise, and sorry, it's difficult to see in this view as well, but if you can, then it gives you a good assessment of the pulmonary artery. It can give you an idea of what the pulmonary pressures are. It can give you an idea of the what the pulmonary artery size is. So in cases of pulmonary embolus, say for example, it would be dilated, and that might be possible to see it here. And it also gives you an idea of the interatrial septum, and we will see that when we go through the details of the view. So the idea behind doing this slide is to impress on you the importance of short axis view and the wealth of information that you can get from it if you get it right. So these are the various levels at which we do the short axis view. This just the cartoon just shows you the various axes we look at. We are also going to look at them in how we see them echocardiographically, but these are sort of a schematic representation. So what you do is that, as we discussed, that you have the mitral valve right in the center of your screen in the parasternal long axis view, and then you rotate the probe anticlockwise by 90 degrees, and you hopefully would land up the short axis view at the level of mitral valve, which is the second view on the right of the screen. And then what you do is that you tilt down. And when you tilt down, what you're actually doing is that you're tilting the probe towards the apex of the heart. So apex of the heart is located where the apical impulse is, and that's formed by the ventricles, or more specifically the left ventricle. The base of the heart is closer to the sternum, and that's formed by the two atria. So the apex of the heart is formed by the two main ventricles, namely mostly the left ventricle. The base of the heart is formed by the two atria. So when you tilt down, what you're doing is you're actually moving away from the atria and more into the ventricular cavities, and in this particular case, the left ventricular cavity. So when you have rotated the probe, you end up at the mitral valve level, then you tilt down, and what you're actually doing is looking more and more at the left ventricular cavity. So first view that you get is the mitral valve view. When you tilt a little bit more down, you get a left ventricular mid-level view, or what is called as a papillary muscle view, because you see the two papillary muscles. And then when you tilt it further, you get an LV apex view. So these are the three views of the left ventricle that you get when you do the parasternal short. After tilting it down for all these levels, you start tilting it back so that it comes to the neutral position, and then you tilt up. And when you tilt it up, and I'm not sure whether you are able to imagine that looking at this picture, when you tilt it up, you are actually sectioning or cutting the heart at the level of the great vessels. So you see the aorta, and you cut aorta right at the level of the aortic valve. So you see a view in which you are able to see all the three valves of the aortic valve, the sort of Mercedes-Benz type of sign, and you see the centrality of the aorta as you see all the chambers surrounding it. And we'll have a good look at it in the next few slides. So this is the parasternal short axis view at the level of mitral valve. Hopefully, if you had the mitral valve right in the center of your screen and the parasternal long before you rotated the probe, this is the first view you're going to get. The left is the sort of the screenshot, and the right is the labeled view. So you see right ventricle on the top. Again, you see it on the top because it's an anterior structure. So you see it closer to the probe. The probe is right at the top of the screen. So right ventricle, which sort of surrounds the left ventricle in this view. Then you see the interventricular septum, the left ventricular cavity, and the mitral valve. So in this view, you can ascertain the relationship between the right ventricle and the left ventricle. Normally, the left ventricle is a complete sphere. If the right ventricle presses on the left ventricle for one reason or the other, reasons of volume overload or pressure overload, like in a pulmonary embolus being the example of the latter, then you might see a flattening of the septum. So this view gives you a good idea, one, of the right ventricular relationship with the left ventricle. Then when you see it in a live clip, you can see the left ventricle contracting and the walls contracting, the walls getting thicker and the cavity shortening. So it gives you an idea of the left ventricular contractility. And what you can also do is do what we call as a regional wall motion, because you see all of the left ventricle walls. You can see if there is one wall which is not moving very well, that should become apparent in these views. Maybe not at one level, but when you screen it across all the levels, you should be able to see a regional wall motion abnormality, and you get a very good idea of the global LV function. When you tilt down a little bit, sorry, you reach the mid level of the left ventricle, or the papillary muscle levels. I'm not sure whether you are able to appreciate in this diagram or not, but at approximately sort of 8 o'clock position and sort of 4 o'clock position, you see protuberances in the left ventricular cavity. These are the papillary muscles, posterior medial and anterior lateral, and these are, you can evaluate those two. And then the same left ventricular contractility with regional and global function as outlined above. You're able to see the relationship of the right ventricle with the left ventricle. If you tilt further down, you reach the cardiac apex, and you're able to ascertain the contractility, regional wall motion at that level too. There is no more left ventricle to go. You've already reached the apex, so you start detilting the tilt that you had started, and you go through the papillary muscle level, the mitral valve level, and then you tilt the probe up towards the aortic valve, and then that brings the aortic valve view, which we are going to see next. So this is the aortic valve view, aortic valve level of the parasternal short axis. You see the aortic valve right in the middle of the screen. This is a sort of Mercedes-Benz type of valve with 3 leaflets. The chambers that you see are all well labeled for you. So you see the left atrium, the interatrial septum. So we're going to go sort of clockwise, starting from 6 o'clock position. You see the left atrial cavity, you see the interatrial septum. Sometimes the bowing of the interatrial septum gives you an idea as to which of the two atria has got more pressure or volume. Then you see the right atrium, you see the tricuspid valve, which is very important to measure the tricuspid regurgitation, and again the details of which are outside the scope, but that's a good place to measure a tricuspid regurgitation pressure if you want to. Then you look at the right ventricular outflow tract, and towards the right of the screen you see the pulmonary valve, and if you tilt your probe, you'd be able to see the pulmonary artery as well. All these views have been demonstrated in a separate clip, so which is pretty poorly done, unfortunately, but you can have a look at it, and there is a sort of a running commentary of the live view of the parasternal long and short axis. So after you've done the parasternal long and short, you go to the apical views, which look at the heart from the apex. The typical probe position in this case is the marker towards the sort of bed, or 2 to 3 o'clock position, with the probe put in at the cardiac apex. So it is sometimes easiest to just palpate for the cardiac impulse and put your probe right over there with the marker facing down. The apical views are done at 3 different levels. So there is an apical 4-chamber view, an apical 3-chamber view, and apical 2-chamber view. There is also a modification of apical 4-chamber view called apical 5-chamber view, which we'll discuss when we look at when we actually do this scenario. So why do we do apical 4-chamber view? Well, it provides a very good assessment of all the 4 cardiac chambers. So you're able to see the 2 atria, the 2 ventricles in the same screen. You are it is possible to assess the left ventricular size and function. It is possible to assess the right ventricular size and function, or get some idea of the function. You're able to see the 2 atria. Again, you can look at their size and function, so to speak, if you like, as to how well things are working there. You're able to see the mitral and the tricuspid valve and the aortic valve later. So we'll have a look at what all it helps us to ascertain. The first position for the apical view is obviously apical 4-chamber, which is the one on the top of your diagram. So this is the sort of position in which you put the probe first, and when you do that, this is the sort of picture you get. So it's a classical textbook 4-chamber view Obviously the ventricle are the anterior chambers, and hence they appear on the top of the screen closer to the probe because they are anterior. The right side of the screen is the left-sided chamber, so left ventricle and left atrium, separated by the mitral valve, of course, which you are able to see well in this view. The right-sided chambers are on the left of your screen, the right atrium and left atrium. You're able to ascertain the relationship between the right ventricle and the left ventricle. It's a very good view to provide an assessment of the relative ventricular size. Normally, right ventricle is much smaller, roughly about half of the size of the left ventricle. If for some reason right ventricle is dilated, that might become apparent in this view. Again, you can look at the left ventricular size and contractility as well. The two walls that you see are the interventricular septum, which is between the two ventricles, obviously, and the lateral wall, which is the free wall of the left ventricle that you see in this view. You're able to see the interatrial septum and the two valves. So there is lots that you can do with this view or assess, and then move on to the three-chamber view. So for the three-chamber view, from roughly about 3 o'clock position, you move about 90 degrees in an anti-clockwise direction, so that the marker is pretty much facing at the 12 o'clock position. And when you do that, what you end up doing is that you end up closing the right side of the heart. So in some ways, you can imagine looking at the left ventricle. Just concentrate on the left ventricle. You see the septum and the lateral wall. Now you turn your probe 90 degrees and you see the walls that are perpendicular to the two walls that you had seen before. So what you had seen before was the septum and the lateral wall. Now when you turn your probe 90 degrees, you see a perpendicular view to that, which means that you're now looking at the anterior wall and the inferior wall. Right? So left ventricle has 4 walls, as is obvious. So there is a septum, lateral wall, an anterior wall, and an inferior wall. So in this view, you are able to see only 2 chambers, the left atrium and the left ventricle, with the mitral valve in between. There are 2 or 3 more structures that are important that you can see, but we won't go into those details. You basically look at the left ventricular size and left ventricular contractility, because you get a fair idea of how the regional wall motions are. You assess the septum and the lateral wall in the 4-chamber view of the left ventricle, and now in the 2-chamber view you are able to see the anterior wall and the inferior wall. The wall on the right of your screen, which is not very well seen, is the anterior wall, and the reason it is not very well seen is that because it abuts the lung, which has air, which is a poor conductor of ultrasound waves, so it is not seen very clearly. And the one on the left of your screen is the inferior wall. So anterior and inferior wall, left atrium, and the mitral valve. If you go on tilting your probe, you get what is called as an apical 3-chamber view. Not much new information from this view. The third chamber is the aortic ascending aorta and the left ventricular outflow tract with the aortic valve. If you look carefully, you can see that this view, more or less, is a parasternal long axis view turned sort of 90 degree clockwise, roughly. So the right ventricle is on the right of your screen, then there is interventricular septum, the left ventricle, mitral valve and left atrium, and aorta. So why are we doing parasternal long in apical, say for example? Well, the utility with this view is that you are able to measure a lot of gradients across the Doppler, and that's why we do this view. But you could well argue that if you have had a very good parasternal long, then this does not really add much of an information. Okay. Now we are going to do the subcostal view in a different presentation. So I hope that you have had some idea about what parasternal long axis and apical views look like. Thank you very much for your attention. We look forward to seeing you next week. Bye-bye.